All right, I see a couple people still hopping in, so we'll give it that other minute as everyone gets connected. Oh man, this one's a little bit peppier. All right, it looks like our waiting room is clear and we are ready to go. We're at the top of the hour for all of our different time zones. So I am in Central Time. It is 2 o'clock here. So thank you for all of our East Coast participants at 3 o'clock on a Friday afternoon for joining us. That is awesome. And we're so thankful to have so many people here joining us today for this webinar. We are going to go ahead and get started. So my name is Jessica Rose Johnson. I am a project associate with SAMHSA's SMVF TA Center, and I am glad to be here with you today and be a part of the TA Center. I'm a Marine Corps veteran myself, so I tend to forget to say that apparently. And I want to go ahead and pass it over to our amazing federal partner over at the VA, Miss Andrea Lee.
Good afternoon, everyone. Thank you, Jessica Rose. I'll be very brief in my remarks and just say, welcome, everyone. First of all, I'm Andrea Lee. I'm with VA's National Suicide Prevention Program, and I help to coordinate all of the Mayor's and Governor's Challenge efforts. On behalf of VA and SAMHSA, we are so excited to be kicking off this webinar series, and we have such a distinguished speaker for you all today, with Dr. Kim Reap, who has done such incredible work around mortality review committees and is such a pioneer in this field. So we are so lucky to have her with us today. Thank you so much, Dr. Reap. We recognize that getting real-time data is a gap in this field, and it's hard to do this work when you don't see the impacts of your work until 2, 3, 4, 5 years later. So this is really innovative work that Dr. Reap is about to share with you all. It can be so powerful in informing your suicide prevention efforts and the interventions that you are designing. So we're so excited to kick things off. I did want to do a shout out. I see my colleague, hello, Stacey Owens from SAMHSA on the line as well. So thank you for joining. And I'll turn things back over to you, Jessica Rose. Thanks, everyone.
All right, so like all great webinars, I feel that people have gotten used to this, but please make sure that you are on mute. We are going to be having a split question and answer period. So we're going to kind of have a midway break, do some question and answers then, and then we'll have some questions and answers at the end. So don't worry, you won't have to hold all of your questions till the very end, but make sure that when it does come time for Q&A, you're more than welcome, even throughout the presentation. If you want to throw your question into the chat box, I'll make sure that those questions get answered. And if you want to come live and ask your question, that's when you'll do the whole unmute and mute yourself back on. So we're so excited, like I said, to have representation from all different time zones. Here are some of the states that registered. So again, thank you so much for your time and being here. I'm really excited to be able to share this opportunity for learning with everybody. So if you want to introduce and give a shout out to the state that you're representing today, go ahead and throw that in the chat. You might connect with somebody that you didn't know from your own state. So we would like to give a quick disclaimer, as always. The views and opinions and content expressed in this presentation do not necessarily reflect the views, opinions, or politics of Substance Abuse and Mental Health Services Administration, or SAMHSA, and the U.S. Department of Health and Human Services, in the Veterans Affairs Administration and Department of Veterans Affairs. So keep that in mind. We also would like to address the fact that we are talking about suicide today and we are talking about death. So if you did not sign up for mortality review committees, this may be a little bit of a shocker for you. But for those of you who did sign up, you know that this subject is very near and dear to a lot of our hearts, and it can potentially stir up things for you. So If you're starting to feel a little uncomfortable or something has triggered something in any form or fashion, please reach out to us. We are very blessed and very lucky to have our very own, the wonderful Dr. Barbara Lattimore. She is a licensed clinician and she is sitting in on this webinar. So if you do need to reach out to someone, please feel free to reach out to any of us, but I would highly recommend reaching out to Dr. Lattimore. And I get the pleasure of introducing our speaker for today. So for those of you who have not had the privilege of knowing Dr. Kimberly Reap, she's currently the Chief Epidemiologist for Washington County, Oregon. So if you had on the flyer, you got to read her bio and some of the amazing things that she has done. But what you will not learn from her bio is she is a dual citizen of both the US and Australia. She was once attacked by a Scottish Highland cow while at a death scene. So one day we'll get the full story from her on that one. Watch out, she's amazing at handwriting interpretation, which many people refer to. It is her famous party trick. And to this day, she has never had a fast food hamburger. In fact, she's only had elk until the age of 14, but don't try and sway her. She's not going to change now. On her last birthday, she was swimming in the ocean off the Big Island when a hurricane hit. So she has lived some pretty serious life outside of the amazing work she has done for suicide prevention. So in all seriousness, though, she's done amazing accomplishments for our field, for our communities, for our people to learn more about suicide deaths and how we can help improve and save lives. So you're going to get to hear more about the amazing things that she's done and how she's done them throughout her presentation. And you can refer back to her official bio if you have any questions about specific details. So without further ado, I would love to pass the mic on to our one and only Dr. Reap.
Thank you, Jessica Rose. I think I showed a little too much of my Oregon there. So if I have any other Oregonians on the call, hello, West Coast. So today we are going to talk a lot about the suicide surveillance system, suicide fatality review, the process that Washington County, Oregon went through, the 5 or 6 years it took to build the system, the results it had, and we will get a break in the middle. So I know it's late for you East Coasters. So thank you very much all for being here, and I really look forward to working with you. Next slide. So my very first day of biostatistics, my professor put this up on the board, and he said, "In God we trust, all others bring data." And he apparently said this to his mother when his mother said, "I love you," and he said, "Show me the data." He was 6. So at that point, I think it was pretty much set that he was going to be a biostatistician. But I think this just underlines a very important part of evidence-based practice and review. Always bring your data to the table. Next slide, please. Our goals for today, we're going to talk about suicide surveillance, what's out there right now, which probably a lot of you are familiar with, what the role of a medical legal death investigation, whether you have a coroner's office or a medical examiner's office, how we built our suicide fatality review, and the things that went wrong with all of the above, so you do not have to repeat the mistakes we made. So that's the general outline today. But first, before we go there, we have to talk about suicide and COVID, because this is just hot off the press, and what better audience to discuss this with. So a lot of you, I'm sure, saw these reports before we had any data that the suspicion that COVID was going to bring a major suicide spike across the country, because you have that combination of risk factors. You've got social isolation, limited treatment access because hospitals were full or people didn't feel safe going, a lot of anxiety, firearm sales in Oregon alone, that it was just astronomical. So these things in people's mind set up a narrative for what was going to happen. And indeed, before the data had even come out, reports about suicide spiking were already in the hundreds without the data. Next slide, please. So I'm in Washington County, and we only have like 612,000 people in Washington County. We're the second most populous in Oregon. And I'm looking at our suicide counts. Now, yes, our suicide counts are very low now, thank God, but They weren't before. And I'm looking at 2019 to 2020. So the red bar is 2020, the blue bar is 2019, and it's getting less and less each month, to the enough that it's raising my eyebrows that we're worried we're going to find a bunch of cases once COVID like sort of calmed down, but that has not been the case at all. So our suicides were going down with 1 month exception. Now, I'm sure, I don't know how many of you saw this JAMA that came out about a month ago, I think. Suicide has officially dropped off the top 10 leading causes of death because of COVID. And if you look in this blue box across the bottom, these are the absolute counts of deaths by suicide across the year. Remember, we add 1.7 million people to our population each year. So even if the suicide rate was stable, you would expect these numbers to go up. But look, in 2018, we're about 48,000. It dropped in 2019, and it further dropped. It's one of the largest drops we've had in suicide counts in a very long time. So it turns out that the suicides not only didn't spike during COVID, they significantly decreased at the national level. So I tell this as a story of caution. When you're looking through your suicide data, be aware if the narrative has been told before the data has been seen, because this is an example where in reality, that's not what was happening at all. And if you go back and look at the cities or states that were reporting suspected increased suicide, you find out they didn't have real-time suicide data. They were looking at things that were over a year old. So just keep an open mind when you look at your data. Okay, I'm briefly going to go, I know everybody on this call is a suicide expert. I certainly am not, but I'm an epi, and I just want to go over some of the existing data sources that we have for suicide. Now, in my office, I have this sign bolted to my wall, and I hear that we might have a state ME or a state coroner here. So she or he probably knows exactly what this says, but this is part of a quote that says, "Let conversation cease, let laughter flee. This is the place where death delights to help the living." And I walk into my office and I see this every day to remind myself that when I'm looking at the numbers, these numbers are people, these numbers are family, these numbers are lives, and our job by honoring the people who have died is to learn and to help prevent suicide deaths. And interestingly, this was put over the first anatomical theater in the 1500s, and you can see it actually posted or carved in stone outside most morgues across the world. Next slide. So these are very well-known sources that can either get at the mental health aspects or directly suicide counts or suicidal ideation. Obviously, we have the VA's report, it's beautiful. We have YRBSS to get at some of the youth mental health factors that might be going on. We have our CDC Wonder data for injuries, wellness survey, Whiskers, BRFS. So these are all national level surveys. Some of them have state level that give us little pieces of information. Now, of course, with all surveys, they are self-report and they may not be representative based on sample size. We know as people have converted to cell phones, it's getting harder and harder and harder to actually reach people to complete these surveys. And in fact, Oregon State, we actually didn't meet our threshold to contribute our data because we didn't have enough people respond to some of these surveys, which is disappointing. So these, this is a huge undertaking for any institution to do national level survey. And so the data may be 2 or 3 years old. That's normal, that's expected. But when you combine all of these together, if you're a state, you can get a pretty good idea of a temperature check of what's going on in your specific jurisdiction. Now, the gold standard, the absolute gold standard for death and injury data is the National Violent Death Reporting System, NVDRS. If I could have a baby with any surveillance system, it would be the National Violent Death Reporting System. And for those of you that might be a little more nerdy, I just want to say the coding manual, like their actual coding book, is the best I've ever read in my life. It's amazing. It has examples. Even my medical examiners loved it. It's really, 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 really good. Well defined. So the National Violent Death, it is my understanding that every state in the country is now participating. Now, it might take a couple of years of collecting data before you can start seeing trends. Oregon was one of the founding states in NVDRS. So we have data from 2006 onwards. And what the NVDRS does is it tries to collect all the information from LE, law enforcement, vital statistics, coroner or ME reports, and kind of, I think it's like over 1,000, 2,000 different variables for each death that they try and abstract from that information. Next slide, please. So these are just examples. This is from the NVDRS site. These are examples of the type of data that the NVDRS will collect. They will evaluate intimate partner violence, physical health problems, relationship problems, weapons used. Now, of course, as we all know, this information and whether it's recorded in the death investigation will vary by state, right? In Oregon, we record everything about the weapon because it is required, like where it was stored, how it was purchased, last time it was used, it's like that kind of stuff. But I know that's very different state by state. So each state is going to have different strengths and weaknesses in these areas and depending on their system. Next slide. So what can you do with the NVDRS? Excuse me. So this is an example of the kind of information you can garner from your state level violent death reporting system. What we're looking at here are male veterans stratified by age, so 18 to 54 and then over or equal to age 55. This is a roll up, so it's multiple years of data. And it's comparing the presence of risk factors or circumstances amongst these two age ranges for male veterans. Now, as you can see, I mean, it's pretty busy, but as you can see, the older veterans have more physical health problems reported. Again, that's to be expected. We'd see that outside of the veteran population too. Intimate partner problem, take a look at that though. It's much more prevalent in our younger veterans than our older veterans. So whereas the mental health report problems at the very top, they're pretty similar. So this just helps kind of start to form differences in risk profiles in areas for intervention potentially. When you start subgrouping, you know, this is male veterans by age, you know, I'd probably split it up into different, you know, to be more representative of which theater they were in, et cetera, but, you know, Oregon might not have enough numbers in all those categories to be able to do that. But this is just an example of what you can do with the NVDRS. Now, here's the some of the barriers with NVDRS. The thing is, the states are not required, the law enforcement, et cetera, are not required to send their reports in for the National Violent Death Reporting System. The only people that are quote unquote required are the medical examiner or the coroner's office or the law enforcement agency that's responsible for the death investigations. So in a lot of cases, the only data that come in to the National Violent Death Reporting System is the narrative statement from the death investigation. Just because they want law enforcement, fire, EMS, all those other systems, the funeral home, everybody who touches at the death scene does not mean they will get it, and it is not required by law for those agencies to participate. And that's a huge, huge issue that we'll go into detail later. But the standardization of the National Violent Death Reporting System is the abstractors, so the people who sit in a room and they read all the information that is presented for a death, and then they decide yes or no or missing. Those are together. We can talk about that for 2 hours if you'd like, but I won't bore you too much. So they decide yes, no on every single one of the hundreds and hundreds and hundreds of variables. So the people that are sitting in the room have never been to a death scene. They are not forensically trained. They're not pathologists. They're not clinicians. They're not death investigators. They have been trained to read an abstract. And we're going to go into why that's a little bit of a problem too. Not that I would want someone to have to go to death scenes if they didn't want to, but trust me, reading the reports is sometimes just as traumatizing as going to the scene. So I just wanted to do a summary of the National Violent Death Reporting System, the pros and cons, because we're going to talk about our suicide surveillance system and how it's similar and fixes some of these gaps. So before I bark at you any longer, I wanted to do just a quick poll question, if Jessica says it's okay. What data have you used to inform your suicide prevention efforts? Have you used the National Violent Death Reporting System? Do you look at your coroner ME cases? Wonder, Vital Stats? Oh, Essence and Biosense. So that's the emergency department data that comes in. So you can look at injuries or report or suspected suicide attempts or something else. So I'm just very curious what you have used out there.
All right, looking like we have a tie.
Oh, okay. You're killing me. What's our tie?
All right. Oh, sorry, I thought you could see it.
Now I can't see it.
I'm just going to keep the answers all to myself. So we have 30% for the National Violent Death Reporting System and 30% for coroner medical examiner case reviews. The next highest, we had 17%, sorry, 5 people said other.
Okay.
4 people at 13% said vital statistics.
Okay.
And then 7% CDC, and 1 person has used Essence Bioscience.
Hey, yay, the Essence user out there, Biosense. Okay, awesome. Well, that's great. So that's exactly what I would expect. And I'm sure many of you have used a combination of those. Oh, there it is. Now I see it.
Oh, there we go. You're waiting on me to click the magic button.
Okay, I'm actually really excited to see that high of a proportion of coroner ME case review. That's really good, because that is the stepping stone to get where I'm suggesting everybody should go. So thank you for doing that. So let me close that. So we have looked at our surveillance systems. We've looked at what data are out there. But what's actually possible? What have people, everybody wants to reduce suicide, but it's very, very challenging to figure out how to do that. Now, there have been several studies in the Air Force and other branches talking about suicide prevention programs. And this is one of them. There are many, but an article like this is what completely changed my mind about what is possible and reframed everything that I was thinking about doing for suicide prevention. So what one of the studies did, they were on a military base, so essentially a closed population. So everybody there, you know, they got their medical care there, they worked there, the families lived there, they're all together. And so what they did in this Air Force study, they had some of the highest suicide rates in any military branch, and they wanted to try a new suicide prevention program. So they collected data, a lot of data, and they figured out one predictor that significantly predicted a suicide in that household above and beyond anything else. Does anyone want to guess what it is? Oh, I know we probably can't talk like that because there are too many of us, but this was fascinating. So the predictor was if military police, firearms, sure, of course, the significant predictor was if the military police had been to the household twice in 2 months for any reason at all. It didn't have to be, domestic violence related or no way. I mean, any reason that the military police went to the household predicted that there might be a suicide. So what they did was when a family unit had that experience, so they had military police come to their house twice in that time period, it was mandatory counseling for everybody in the household, the kids, the parents, everybody had to go to counseling. And within 2 years, they dropped their suicide rate to almost 0. So what that told me, and this is a closed population, again, this is not like our cities or our states where people come and go, and I understand that. But what that told me was they found the predictor. It doesn't matter why. Like the reason why that doesn't, it doesn't matter, who cares? They found what the marker was for, hey, there's enough going on in this households that they are at risk. So I wanted to figure out what that combination was, if there was a marker like that or something like that for Washington County. So I did what any insane person would do. And I went and found our medical examiners. So in Washington County Public Health, our medical examiners are actually inside of public health, and that's unusual. Usually they might be with the DA's office, or they might be under the police or things like that. But we have at the county level, our medical legal death investigators are county employees. And then we have 8 board certified forensic pathologists at the state level that perform the autopsies for the whole state. So that's kind of how we are set up in Oregon. So it's not a true state-based medical examiner system, but it's flirting with that. Maybe one day we'll get there. So nobody talks to the medical examiners because they're the creepy people that deal with dead bodies, and everybody just avoids them and they hide in their dark corner in the office. And nobody had even spoken to them. So I walked over to, this is Charles here in this picture, and I walked over to Charles and I said, "Hey, Charles, I'm Kim. I'm an FB, and I would like to go to a death scene with you." And he said, "You're that weirdo that does outbreaks." And I was like, "Yes, and you're the weirdo that does death scenes." And then we were besties from then on. And one scene turned into 2 scenes. We had 7 in one shift. They worked 48 hours on, 72 hours off. And then it ended up turning into 200. And now for that privilege, I now supervise the medical examiner's office in addition to the EPIs. So the reason why I wanted to go to a scene was because I was following the data trail. We know information is lost at every single step, right? This is where the death investigation is, where all the information starts. That's where everything starts being collected. So I was wondering what actually happens at a scene. And I know across the country, because I've been across the country working with different coroners and ME's offices, and the style of investigation, the expectation of investigation are very different between each jurisdiction. So this is only what happens at Washington County. So I had to do a 3-hour psych evaluation before I went out to a death scene, which is standard county policy. And one of the most interesting questions that was asked was, how are you going to do with a dead body? And there's only one answer to that, unless you have done this work before or have worked in an industry like that, like a funeral home or, a medic or something like that, where you've had that experience. There's only one right answer, and that answer is, I don't know. Because you don't know. Next slide, please. So I said, I don't know. And, I'm terrified, right? To prepare, I watched every single episode of CSI, took all the notes. I knew I was going to arrive in a black county issued Hummer. Obviously, I needed to wear heels and sunglasses, regardless of the time of day or night. And it was going to be really dramatic. I mean, it was going to be a big deal. We're going to show up with our bags. So the reality of the situation is not nearly as sexy. So this is an example of a scene kind of start to finish, where I learned about the process and the information they collect. This person, we went from seeing the text messages on this person's phone to their partner, the Googling of the overdose on sleeping meds, the receipt, buying the sleeping meds, the empty bottle of sleeping meds on the stove, and then finally the suicide with toxicology from this, from consumption of the over-the-counter sleep aid. Now this is very clean, right? This is a nice, super clean example of what can happen at a scene. Now, most of them are not that clean. But what I did notice, and what was exciting to me, was that every single thing that I could possibly want to know as an epi was already being asked. Everything I could possibly want to know, they have to go through in their differential to get to the manner and cause of death. So I was like, okay, this is awesome. So here is the official list of the investigative duties of a medical legal death investigator, at least where I live. They have to ID the body. That is their job. That's not the job of law enforcement. They are legally responsible for identification of the body, no matter how long that takes. They have to approximate the date and time of death, the circumstances surrounding it, and of course, the cause and the manner. Now, cause of death means the actual literal cause. So, a gunshot wound or et cetera, et cetera. And the manner is like the accidental, undetermined, homicide, et cetera. So these are the 5 things that they have to do. And what you may notice is not on this list is suicide prevention. I don't see it anywhere on there. In fact, prevention at all is not their job. It is not their job at all. Their job is to determine the cause and manner of death. That is what they're paid to do. That is what they're trained to do. So I am coming in this with a very public healthy viewpoint of how can we use this information to prevent, and they're like, no, that's not our job, it's cause and manner, and then sort of finding each other in the middle. Another thing that was very interesting was how familiar the death investigation process felt. Now, as you can see on the left, that's one of my staff. We're investigating a norovirus outbreak in a temple, and we actually isolated norovirus from the carpet 6 weeks after the incident, after it had been professionally cleaned twice. And on the right, we have one of my medical legal death investigators, Kate. They're about to go into that trailer that has been abandoned for 2 full months, and there's a person in there. But the similarity, even though, we in outbreak investigation, we do have deaths, but that's not necessarily the focus. It's on prevention. The process that they use was very, very similar in terms of the decision-making tree of what we do in an outbreak investigation. Very similar. So I thought, why don't we make a data collection instrument kind of what we look like, what we use in outbreak investigations, except tweaked for suicide. So as I confessed my love affair for NVDRS earlier, even with its problems, we built this. So basically what we did, it's called Surface as a nod to Burfus, but you will actually see it published as the CRAP form, the Consolidated Risk Assessment Profile. We published that in the American Journal of Forensic Pathology because that's what the MEs named it, and it was just another form to them. And what it is we took all the variables that were in the National Violent Death Reporting System, and instead of sending that information to an abstractor to go into the state data, to go into the CDC, we're actually having our death investigators who did the death investigation fill out the data collection information for their own scenes. And that's very novel. Nobody had really done that before. And through their own lived experience at the county, the shortest, the least amount of seniority I think I have is 9 years for my staff, and I have somebody that's been 22. They know the county, they know what happens, and they suggested adding 2 circumstances and risk factors that were not collected at the time by the CDC. One of them is social isolation, and the other one is non-fatal self-directed violence, because they had seen that a lot in, not a lot, but they had seen that in the community when we had deaths by suicides. So I told you that NVDRS have these beautiful definitions for each of those variables. So we took those and we used those, and they're very helpful and they're good, but we had to think up a definition for social isolation. And what we did, and this has been adopted as a social isolation definition in terms of death investigation. If you or I were to pass away tonight, how long would it be before someone found our body? An hour, 5 minutes? If you live alone like me, maybe if I didn't show up to work on Monday, although it's virtual, but still, it wouldn't reflect on that and how long it would take for some, I mean, it could even be minutes, right? So we are classifying people as socially isolated who have been passed away in their home for 2 to 3 months before anyone had any sort of checkup on them or things like that. So that's a big hallmark for social isolation. So is, of course, you know, the standard. They don't appear to have any social contacts. They don't have physical mail or email or any evidence of any sort of community or group. We'll talk to the neighbors and they'll be, I saw Fred, but, you know, didn't talk to him a lot. He's lived in this house for a long time. And you can see social isolation as a problem. So after a few years of data collection, oh, can you go back, please, Jessica? Thank you. After a few years of data collection, we needed to see if our surveillance system was worth it, because we shouldn't keep doing something if it's not getting us any new information. So what we did is we took the same 133 deaths and looked at the difference in the prevalence of risk factors and circumstances for those same deaths in our system and Surface versus the violent death reporting system. So if these 2 systems were identical, the bars would completely overlap. As you can see, that is not the case. The light gray bar, so as you can see, depressed mood, Surface found that as a risk factor 80% of the time, whereas it's about 55% of the time it was reported in the National Violent Death Reporting System for Oregon. Now, the most jaw-dropping difference was recent crisis. I mean, this one, our MEs reported, you know, 72% of our deaths by suicide were experiencing a recent crisis. And what does a recent crisis mean? That means that that person, it's a point event, that person's life will now be defined as before and after that event. It could be a DUI. It could be losing custody of the kids. It could be any sort of financial, it could be bankruptcy. It could be a health diagnosis. It could be any of these things. But our investigators were reporting a crisis in the overwhelming majority of our deaths, whereas that was not coming through in the violent death reporting system. And indeed, all the risk factors and circumstances on here are statistically significantly different. And we found that the violent death reporting system underestimated the prevalence by half on most of the risk factors. Now, I don't know about you, but I would probably make some very different funding decisions if 50% of my data weren't there. That's a really big deal. And this is at the county level, not at the state level, because I can only look at our county ME data. But we published this. It was really eye-opening about the importance of the data loss between the death investigation, just getting it to the state. I mean, these are the same deaths. They should be identical, and they look like they have no relationship whatsoever. Next slide, please. So why are they so different, right? That's the probably $1 billion question. Now, one of the things that terrified me as an epidemiologist was the amount of information going to the scene and everything that's said from all the people and all the interviews, and then looking at the report. The information difference is astronomical. So we might be at a scene for 3, 4, 5 hours, something like that, if it's not a homicide. And the report will be, I don't know, 5 paragraphs, single spaced. And remember, the job of the death investigator is to determine manner and cause to the point where the pathologist is comfortable with the decision, will sign out on the death certificate, with or without an autopsy or toxicology. That's their call. So we can't blame the NV, and I don't blame the NVDRS. If the information that was said at the scene isn't written in the report, they can't abstract it. Of course, it's not going to be there. So there may have been questions asked about, did this person have a physical violence problem with their partner, or those kind of things. And although my public health brain is going, that's really important, if it did not directly contribute to the manner and cause of death, it does not go in the report. So that's why we built that surveillance system, because we needed to capture all that information, because it's not necessarily going into the report. The surface allows us to capture that without them having to write a lot. In fact, it takes them 3 to 4 minutes to fill out the entire surveillance instrument. I'll talk about that a little bit more later, but we built it out. It's written in the way that they do the investigation, that they do the reports. We worked really hard to make it as easy for them as possible, and we finally got there. So that's the first reason. If it's not written down, we can't expect someone to abstract what's not there. Another big one, and this one was kind of shocking to me, neutral language. So this is actually at the Scottish Highland Cow. I don't know if you guys have seen a Scottish Highland Cow before, but oh my gosh, they're like teddy bears with horns. The with horns part is the problem. Yeah, so we were out in the middle of the very, very rural part of our county. There's no cell phone coverage, satellite only. There's not even fences for the farms. And we report to the scene. And upon pulling up at the scene, there were hundreds and hundreds and hundreds of empty beer bottles scattered outside of the trailer. And there were garbage bags full of bottles. And upon interviewing the legal next of kin, the brother of the person, Charles, interviewed him and said, did your brother have a drinking problem? And this is part of his job. That's a standard question. And the brother said, no, he's just thirsty. And he was serious. So we go into the trailer and we actually have to take bottles out before we can even get to the body. We can't get to the body because there's so many empty bottles piled up. Upon inspection of the decedent, the smell of alcohol was very strong. And of course, the toxicology came back. His blood alcohol was very high. So to me, again, I am not a forensic medical legal death investigator. I'm just an epidemiologist. I would say that person likely had an alcohol problem. I would say that is supported from the evidence at the scene in my head. So I read Charles's report. It said exactly what happened. We showed up, there were all these bottles. This is what the brother said. We had to do this in the trailer. This was his blood alcohol level. I mean, it was exactly what happened. But Charles did not write the words, the decedent had an alcohol problem. And because that phrase was not in there, it was coded as no for alcohol problem. So that was a very interesting, and I have a lot of examples like that, where the language in the report is so professional and clinical and not leading, if you will, that maybe the abstractors aren't comfortable taking that leap and saying, yes, this is evidence of an alcohol problem, for example. So neutral language was a problem. Another one, death investigations aren't standardized at all. Now, this might be my next battle on earth. Like, I haven't decided if I want to take that on and try and work on that before I die. We'll see. We'll see. That's a big one. But even on my own team, one of my investigators is a literature major, and her reports are so beautiful. They're like 7 pages long. And I'm always like, what's going to happen? Like, they're just, the doctors hate it, of course, but I mean, they're really, until they have to go to court, they're really, really good, incredibly detailed. And I have people who've been doing it for a long time. Their reports have everything they're supposed to have, nothing more, nothing less, clean. So even in my own office, I have a very different level of information between my investigators that go into the report. Now, they're all approved by the pathologist, so they meet the pathologist standards, but it's very different there. Now, you go into a rural county, for example, like on our coast, where there aren't any death investigators. It's a part-time law enforcement that may or may not have had any training in death investigation, kind of making those decisions. And again, if you don't do something every day, you know, the quality, it's harder to stay up to standard on that. And again, there's no funding. I mean, nobody wants to fund the death investigation system because it doesn't make any money, right? So there is a huge difference. I've been all over the country, and I've seen ME offices that are glorified body removal all the way to like 15-page single space reports. I have seen it spans the entire range, and it comes down to what the pathologist or the coroner will accept for death investigation. So that's a big problem. Additionally, fat finger, human error, just typing the wrong key. We found that about 30% of the time. So after evaluating all of this and looking at our surveillance system, we decided to keep our surveillance system going, surface going, and not use the NVDRS for our own data analysis. So that was the evaluation of our system. Now, if I haven't sold you yet, this hopefully will get you there. So usually when you ask for something, you have good, cheap, or fast, pick 2, right? And I would like to argue that death investigator data gets you the miraculous trinity of good. It doesn't get any better than someone who actually did the investigation. There is no better source of information. Cheap, 3 minutes of time. That's not a high dollar cost. The epidemiologist built the system, they click buttons. That doesn't cost a lot of money. And fast, again, instead of waiting 3 to 4 years for state level data, I'm getting it in real time. So I honestly believe if you have good, solid death investigations, there is no better source of information as an epidemiologist for public health interventions than the people who actually do the death investigation. So that is my preaching there. And before we go on to suicide fatality review, if it's okay with Jessica Rose, I'd like to take a pause and go over any questions on suicide surveillance, like the surveillance system and the data systems, before we switch to more the qualitative suicide fatality review.
So this is your intermission break for questions. And
one.
I have one to start us off with. So you had mentioned about how the medical examiner fell under your more of the public health side. Do you think that that was a benefit for you to be able to go out onto the scenes, or do you feel like there might have been some hindrances if they fell into a different department or different agency?
So because I physically saw them in the building, even though I had not had verbal contact with them, I felt okay to go talk to them. Like, they'd see me around, I'd see them around. So there wasn't that barrier. I mean, when I went to speak to them, I didn't know they were in public health. I figured they were part of the sheriff's office or something. I had no idea. It wasn't until I got assigned their program that I found out that they were actually inside of public health. So before I went out on the scene in Oregon, the medical legal death investigators get their authority from our state medical examiner. That's where the power comes from. So independent of where that position the investigator would be under, I would still have to have permission from the state medical examiner to go to a death scene. So independent of where they are, because that's their butt on the line, if you will, right? Like if I go and do something stupid or vomit or pass out or whatever at a scene, that's going to be on them. So I received explicit written permission from our state medical examiner, our chief, and before I went out. So it didn't really matter. The stuff that we're doing now in terms of giving them full access to epidemiologists is absolutely a benefit, but the initial going out with them, the ride along, that didn't really affect that part of it. Does that answer your question?
Yes, and that actually brought me to, you had mentioned about having the psych eval. Is that something that, is that like an annual thing they do? Is that before every scene you have to have that conversation? I know you said it was about 3 hours, so I wouldn't imagine that happening before every scene.
No, it's something that if you are going to take a person who is not an ABMDI certified medical legal death investigator out to a scene, that is part of it, because as uncomfortable this is to say, there are some people that want to go to death scenes for reasons that maybe aren't as appropriate as others. They may have a fascination, they may have, it might be trauma, it could be a million things, but it's basically designed to screen out looky-loos, and if you have some sort of deep-seated psychological homicidal issue that you're trying to work out through going to death scenes or whatever, I don't know. But yeah, it's more to just, is this person, nothing can tell you if you're going to do okay at a scene. I want to be clear about that. It's more about your intentions going in and where you are at mentally. Like, I mean, I had to go over every childhood trauma that like it was a lot. So I was exhausted after that, but I somehow got the go ahead. So yeah.
I can see that being a real benefit even to the person in the family that's affected by this death, is really just making sure that people who are there should really be there. So I like that that's part of that screening process.
Yeah.
So we have a couple questions in the chat.
Awesome.
On the topic of standardization, so this is from Dr. Gamble. I'm wondering what your thoughts are on demonstrations of death or determinations of death as suicides by death investigators, particularly when evidence of intent may not be present. I stumbled a little bit, but I think you got the question.
Yes, that's a beautiful question. So the death investigators are not physicians, they are not pathologists. And the flip side of that, if you took, outside of LA County, if you took a pathologist to a death scene, they would have no idea what to do. Like, that part isn't their job. So they actually depend on each other. So for example, Dr. Gamble, the part where we get really into that gray area you're talking about, where we might not see clear, is usually around overdoses, determining whether they were intentional or accidental. And in that case, every single death that we have that we take jurisdiction of, the case is reviewed with a pathologist at scene. So basically 24 hours a day, 7 days a week, the investigator will call the doc and go through it and say, do you want this person in for an autopsy? Do you want me to take toxicology? What do you think? This is what I think it is. And so if it's not clear, like it's in that gray zone, usually depending on age, 3 strikes, you're out. If you're over 60, if you have 2 chronic health conditions, I forgot what the other one was, but there are like 3 things that it's like, on an autopsy. And again, it's the physician's decision. That is not the investigator's decision. We would usually take toxicology. We absolutely would take toxicology on all of those. And then whether the doc wanted to see the decedent for an autopsy would rely almost probably exclusively on age and existing of chronic conditions. And if the doc wants, we bring the person in. So they don't make decisions on their own without running it by the person who's actually going to have to sign the death certificate. So there's protection there in terms of checks and balances and quality control. Does that answer your question?
Brilliant, Dr. Repp. Thank you. It sounds like both are deaths of despair anyway, and in their own right are worthy of investigation and further study. Thank you.
Absolutely. And interestingly, different jurisdictions have adopted the suicide surveillance system that we built for overdoses because the risk factors are nearly identical. Exactly right.
So could you tell us a little bit more about Essence and BioSense? Specifically, someone asked, is that something that anyone can get access to, or is that maybe a paid subscription or only certain titles or positions can get access to that?
Okay. How exciting, an epi question. So Essence is a national surveillance system, which depending on your jurisdiction, a certain proportion of your your emergency departments, your urgent cares will report their data, their charts into it once every 24 hours. So because it has fully identified patient information like name, date of birth, chief complaint, discharge diagnosis, basically everything, it's really restricted. So in public health, my EPIs have access to it, my analysts have access to it. Interestingly, medical examiners don't have access to it, but we have the EPIs check it. The medical examiners have access to actual medical records, like that's what they need. So usually the access is restricted to a government agency that needs that information for their reporting duties, or they're responsible for surveillance of something. Like, I don't know if you guys remember, it's a blur now because of COVID, but we had that huge eclipse and we were watching the Essence surveillance system for eye injury to see how many people showed up in the emergency department because they stared at the eclipse without the glasses on, and snake bites, and we had a lot of heat exhaustion and those kind of things. So it's a very good warning system for what's coming in the ED. Now, we are very fortunate in Oregon to have 98% of our hospital and ED systems reporting into it. Some places only have 5 or 10%, so you need to check with your state to see how the reporting is set up for your state. But if you can either partner with someone in public health, or you can request your own access as the VA, of course, and you just have to fill out a form. It doesn't cost any money, but life away. And the kicker, the hard part about Essence is you sign a contract saying you absolutely will not release any of the information under any circumstance, which is kind of hard because, my whole epi team, we're sitting in a room like, 20% of our visits are for people that are going blind. And, my administrator's like, so what's going in the emergency department? And I'm like, because, I can't say. So it's dangerous in that sense because you can keep the information in your head, but you can't publicly release it or talk about it with anyone who doesn't have Essence access. So it's pretty locked down, but it's a very useful tool and you can use it to find anything like I said, snake bites, blindness, suicide attempts. It's not great because a lot of clinicians won't actually mark suicide attempt, even if it's kind of clear that it might be. But yeah, it's a great system for just watching what's going to hit. Like that's how when COVID started, when we started seeing a bunch, it's our flu-like illness coming in, and we could see it, 48 hours before you saw it come in another way. So Essence is pretty awesome. Sorry, I probably went on way too long about that.
I love hearing about it, but now I'm like, oh, I can't get access to it. What a bummer. So it's cool to hear that something like that exists to be able to benefit. We do have a question from Miss Andrea Lee.
Hi, thanks.
Hey,
Dr. Repp, I've heard you speak before, and I just feel like it's a life-changing presentation every time I hear you speak. So just wanted to kind of wearing the hat of, we have a lot of folks on Governor's Challenge teams who don't necessarily come from public health and maybe are more familiar with the military and veteran community, and and might not be as familiar with kind of how to first get something started around working with medical examiner and coroner's offices. So where would be a good first place to start as they're thinking about how to collaborate on this?
Okay, this is kind of obnoxious, but I'm going to say this, and I have played matchmaker across the country with Emmy's offices and coroner's offices and the different systems because it is really hard to talk to them. And So NAME, National Association of Medical Examiners, is the national conference that all the forensic pathologists and coroners go to in the country every year. And we won an award there. So we had contact with a lot of different coroners and MEs, and they gave us that award, was their official endorsement of our surveillance system. So it's possible that whoever you want to talk to may know about this or have heard about this, just because, you know, there are only 400 pathologists in the entire country. So it's a very small community, but I would be happy to either connect you with your public health people that can connect you with your coroner ME's office, or you can reach out directly. I mean, for your jurisdiction, you could just, I know most of the country is actually on a coroner system. I mean, you can just reach out to them, or I'd be happy to connect you with them. But we work with RVA on a lot, and we've worked through data sharing agreements, and you can be in the VA and military systems and have access to Essence. That is possible to do that. You're just going to have to sign your life away, but that's not unusual for data paperwork. So you can Google them and look it up, but honestly, unless you're calling in a death, they don't usually answer the phone. So it's kind of better to do a warm handoff. So you can either talk to someone like your DA, or if you have friends in law enforcement that work with them a lot, because those two systems will work together. You could reach out to them for an introduction, or just go for an email, but they're not very responsive to email in my experience.
Okay, well, we'll definitely take you up on that offer. If there are any governor's challenge states that are starting to embark on this journey, if you guys are not connected with your public health office, I think most of you are connected with your law enforcement counterparts. So, but if anyone needs assistance with that, please reach out to VA or the TA Center, and then we can get you, we may take you up on that offer, Dr. Reap, for that matchmaking.
Happy to help, man. Happy to help.
Awesome.
Right. Do we have any more questions in regards to the suicide surveillance and data piece before we move on? Going once, twice. All right, we'll move on then.
Thank you. Now, in public health, we are required to be trauma informed, which is new for us. So I would tell everybody to go take a bio break, but I know we're going to keep going through it. Thank you for hanging in there with me. We're totally shifting gears. We're going to walk through what a suicide fatality review is, or at least how we do it in Washington County. I'm going to go through the different documents, why they're important, and not to read the documents, just to kind of frame it in your mind. Like, this has a very specific purpose, and this is why we do it. And then go through a couple examples of how we actually do it. And then I'll tell one little quick story, and then that will be that. So we're going to start with a suicide fatality review. Okay, so how the heck did we get started on suicide fatality review? Well, suicide was identified as a top health issue in Washington County, and we formed a suicide prevention council. And this council is made up of high-level decision makers. So, you know, in the healthcare systems, they might be the CEOs, or in law enforcement, it might be a major. Basically, the person in each agency who has decision-making authority, representative across as many different communities, agencies, and businesses that would be willing to participate at the Prevention Council. And so the Prevention Council said, hey, want to do a suicide fatality review? And I was like, I've been to a child fatality review and it was horrible. Yeah, let's do that. And so we were charged, we as in epidemiology, were charged with developing a suicide fatality review. And at this time, this was back in 2012, maybe 2013. It was brand new. Again, the only model we had was child fatality review, which in my jurisdiction is basically a 2-hour meeting to figure out how to blame the parents for the death. And it's not really focus-based, or, you know, it started from a really good place. You know, that's how we got seatbelts and all these sort of reducing child injury. But in my particular jurisdiction, it wasn't quite the direction we wanted to go. But I knew we needed a death investigator. That was very clear. And EPIs. And then at this time, when we started the suicide fatality review, we actually did not have a suicide prevention coordinator. That came in through a grant probably 2 or 3 years later after doing this. But basically, we just started with an EPI and investigator trying to brainstorm, what are we going to do? How do we do this that we were charged with? So, oh, the memories this is bringing back. This is so much better than COVID. So the first thing we knew is we had no funding, 0. We did not have $1. So anything that we were going to do had to be magically manifested through in kind. Child fatality review is a mandate, meaning the parents or next of kin cannot opt out. They do not, the state or the jurisdiction does not need permission to review the case. And that's because it's legislated. Suicide fatality review is not legislated in Oregon. So that is, we knew from the beginning we were going to have a consent sort of process to be able to review the deaths. Who's going to own the group? And by own, I mean take responsibility on paper for it. Is it the medical examiner's office? Is it public health? Is it HHS? Do we have law enforcement? Like we had to figure out whose baby this was, so to speak. HIPAA, I don't think I have to tell anybody in the VA about the HIPAA and family privacy and the absolute top concern that is in terms of respecting family privacy, following all privacy laws. And remember, with law enforcement versus public health, you have one is HIPAA exempt, one is not. There's a lot of complication there. We needed a legally binding confidentiality agreement to be able to even sit in the same room, even though we were all, maybe public health, we still had to have a confidentiality agreement. We knew we were going to share very incredibly sensitive information between many partners at the table. And at this time, again, this was back in 2012, and I think a couple states have actually mandated a suicide fatality review now, which is really badass. Oregon hasn't got there yet, but at this point, we reviewed examples that were just starting in Michigan, New Hampshire, and Fresno County, California. So this is what, we're sitting at the table for our first meeting, and these are the things that are going through our mind. So we decided on what we wanted what we didn't want our suicide fatality review. We did not want it to become a child fatality review, not in the sense of the data collection on that's beautiful, but in terms of about finding intent or blame. That is not going to necessarily help save lives. So we didn't want to have that focus. This was not a psychological autopsy. That requires very specific training. It has a very different intent. It's, in a psychological autopsy, and probably many of you already know, I mean, that's a very rigorous process where you talk to the person's friends and family and neighbors and basically every aspect you possibly can to really get a deep psychological understanding of that person's state of mind before they passed. This is not a psychological autopsy. We were not trying to replicate that process or methodology. We were also not going to focus on questioning the forensic investigation. So I don't know how many of you sat on child fatality review, but it's really easy to armchair an investigation when you've never done it before and have no training. It's kind of like how everybody's an epidemiologist right now in their country. I've learned so much on Facebook. So the point here was not to be like, well, why didn't you do X to the death investigator or the coroner or the ME? And interestingly, we did not want to focus on the individual. So we want the individuals to be used as examples, but the focus was really to try and get at system level interventions. And we're going to go into a lot more detail about what we focused on. But this is what we were like, okay, we don't want to do this. This was our don't do this list. And guess what happened? So just quickly an overview that I'm going to go through now, what's up next. I'm going to these are the steps and the paperwork involved in each of these steps. So you have a death, and then a death investigation occurs. So somebody goes out to the scene, whether it's law enforcement, MEs, coroner, somebody goes out there and does a forensic investigation, and someone signs the death certificate as a manner and cause of death. That involves writing a narrative report, and usually there's evidence involved. It could be photographs, it could be autopsy, toxicology, it could be notes, etc. So that's all in the realm of the death investigation part. So the next step we're going to talk about is getting consent from the family for information release. And then it kind of shifts over to the committee, the Suicide Fatality Review. We've got charter, confidentiality statements, roles and expectations. That's of the people on the committee. And then we have the actual meeting itself. And we're going to go through each of these. Okay. Now your report in your jurisdiction may look different than this. There will be a quiz on all the fields shown on this slide in 15 seconds before we're done. But no, this is basically the official death record that has to be filled out. Not all of it, of course, it's just the top little part where we're collecting standard information that's required by vital stats, marital status, found by, et cetera, et cetera. Now, a part of this that isn't shown is the narrative statement. So the person that goes and does the death investigation has to write a statement that would hold up in court to say, this is how I got to this manner and cause of death. This is the official document that is the record that says, I am saying this is a suicide by, hanging because X, Y, Z, and it is the defense for the manner and cause of death decision. And it is signed by whoever is legally authorized to sign that in your state. Consent. Now, if we have any lawyers in our group today, I can hear and feel the heart palpitations about what I'm talking about doing. And we have some of the most conservative legal counsel I've ever experienced in my life at Washington County. So this took years and years and years and years to get the consent form to the point where our lawyer or county counsel was like, okay, that's fine, we're good. And after we developed it, I am very excited to say it is so conservative that is held up in New York, California, like it is held up anywhere. Like they literally have done logo changes and changed, took off Washington County or whatever, and it is held up without modification across the country. So it is that conservative. It's that much of a lift for consent. So what this letter is, well, we have a cover letter, and that's not shown, but it's just a very brief cover letter saying the intent of this. This is included. It's a consent for release of confidential information. In Oregon, this goes to the legal next of kin. And the lift that is asked of this person is they have to write the name. Well, we put in the deceased name, date of birth, and date of death. They have to state their name, and they physically have to mark, and the list is a lot longer than what's shown here, what agencies they give permission to share information. They have to sign it in front of a notary and then enclose it in our we paid for the little mailing envelope and they send it back to us. So that is the lift asked to do the consent form. And in Washington County, we have about 35% consent, which was astronomically higher than we expected. New York that adopted this, I think they're about 22%. So it's different across each jurisdiction. And that has to do with how long you wait to send the consent form, I think, which I can talk about later. But this is the heaviest lift out of everything, I think, not emotionally, but in paperwork to do, is getting something that meets your lawyer's expectations for consent for sharing information. Confidentiality. So we have two different confidentiality forms. We have one that is signed by everyone before they become a committee member. Like, these are the expectations before you go in of confidentiality. And then at the beginning of every single meeting, we also have a confidentiality form. Like I said, our lawyer is very conservative. We have a confidentiality form signed at the beginning of every single meeting, and they are kept on file for that meeting. And, basically it says exactly what you would think, you can't disclose this information in any way, et cetera, et cetera. Charter. Now, I know a lot of groups have a charter, but this became an absolutely critical document for us. So confidentiality talks about what you can and can't do. The charter talks about why and how. I think our charter ended up being 7 pages long, and it took years to evolve it, but it explicitly says, and it's public, so the family can see it. Like, we had families asked to see the charter, so we sent it out to them so they can have a better understanding in their own time of what we were asking and what we were doing. The reporting process, the consent process, like it goes over, it's essentially kind of the instruction manual of the committee, or the suicide fatality review. Now, this didn't come up too later. Now it's in our charter, but roles and expectations, and this will go into our lessons learned a little bit, but one of the key factors of having an effective suicide fatality review is the same people show up. You have one person from each organization. If you have a new person show up each time, it really slows the group down, and the people have to learn the process and they don't show up next time. So roles and expectations, like, clearly lined out, like, you are committing to come to this meeting. You will have one backup person, and you're expected to do your homework before you come. It's very, very clear about what the expectations are. And, if we had a member that didn't meet these expectations, they would get one warning, and then they were removed from the committee. So we did have people reapply, and, we worked it out, but this is, out of respect for the families, out of respect for everybody that's sitting at the table, the trauma involved. This just make sure everybody shows up to play ball. And it's really important. The most common question for suicide fatality review is, who should be at the table? Now, after years of doing this, I can tell you who's at our table, but we started with the MEs, the EPIs, law enforcement, and I think that's actually it. We only started with 3 because we had no idea what we were doing and just wanted to try. So now it has evolved to, we've got the MEs, EPI, the disability, aging, and veterans. So these are Washington County programs, not Washington County public health programs, but capital C county programs that are at the table. And these are parallel at the state level, right? You've got the crisis team, commitment team, mental health, EMS, developmental disabilities, and then externally, community members. So people that aren't government employees. We have, of course, we have the VA, we have our crisis line, the local and national. We have a fire chaplain who reports to every death scene. He's specially trained in crisis, and he's with families, and he's a chaplain at our fire. He's amazing. I love him. We have the FBI at the table. We have NAMI. Faith community leaders, we're going to go into that a little bit later, but it's really important to make sure you have as many different faith leaders at the table as possible. We have every major healthcare system, health plan at the table. Any of our substance use treatment centers are at the table, and we have multiple inpatient psych nurses. So anybody who does like intake on that, works with imminently suicidal people on a daily basis, is at the table. And we have a lot more different agencies than this at the table, but I wanted to give sort of a taster of when you grow and you're fully built out. This is something that these people are really good to have, are important to have at your table. So, how I talked about the pre-work. So this is the beginning. So before the actual suicide fatality review happens, this is what has to happen. There will be a designated death investigator. Ours is Adam, and I think you'll see him later in here. And he keeps a list of all our deaths by suicide. And in Washington County, and I'd be happy to talk about this if anybody's interested, we exclude murder suicides from our suicide fatality review. After the death occurs, we wait 6 to 8 weeks. And then the death investigator sends that letter I was just talking about. So it has the cover letter with the paragraph, and it has the request for consent information, a physical letter to the legal next of kin. If we get the consent form back, the death investigator then prepares the packet for each case. So it has that medical examiner narrative, that form that we showed at the beginning. It will have, we do not include photos. We don't include any autopsy photos. If there was a note left, we do include a copy of the note or any photos of evidence that might be interesting. Okay, random side note. And this is probably really technical, but it's fascinating to my epi brain. So what does count and doesn't count as a suicide note? So for example, if you're looking at somebody's dresser and they spell goodbye with a necklace, like they write out the letters with a chain, that does not count as a suicide note. Interestingly, there's a very formal definition for what counts and what doesn't count. But if there's something like that, that does not have any pictures of a human or fluids or anything in there, they will include that, but it'll be cropped down to something like just the note or a screenshot like I showed before of the cell phone, something like that. The epidemiologist pulls the surface data from each case. So Surface is our suicide surveillance system, as you know. That does not require consent from the family, and that is done for every single suicide. So when we get permission for the family for the fatality review, an epi will pull out all the data that was filled from the surface entry. We'll include autopsy or tox, but again, unless you're a pathologist, that's not super helpful information. The ME will interpret it and say, you know, this is a fatal level of blah, blah, blah. The investigator includes a signed copy of the consent form. We require everyone to physically look at the consent form for the family before we review the case and make sure their organization is checked and they are allowed to share information. We are very, very consistent on that. That's really important because, you know, for example, we'll have deaths where they don't allow sharing from law enforcement. So law enforcement has a ton of information and they'll say, I have a ton of information and we cannot share it because the family did not consent. So that's why it's really important to have the list, and that's why that legally switched to that. And then we use a system called share file, the investigator does, and basically prepares this entire packet for each decedent and sends it out about 2 weeks before the suicide fatality review meeting. And share file is a secure way to send this. Woo, meeting structure and location. So you know how I kind of talked a little bit about who owns this and, you know, from a political perspective, what's best. And it turns out for us, it was best if the medical examiners own it. And that's because by statute in Oregon, they are independent. So they're completely independent of law enforcement. They're independent of, you know, authority wise and decision-making wise of the DA. They are independent. So we thought that they would be viewed as the most neutral. And interestingly, people respond a lot better to medical examiner mail than public health mail. Like I think ours just goes in the garbage for everybody, but people actually opening things from them. So that's another benefit. So we decided that the medical examiners will own this, and we held it at a government building that the public could book. So it wasn't like we didn't hold it, and we held it inside of a space that was publicly available, not so people could come, but just for the perception of use of government resources. We just wanted to be as neutral as possible on the meeting location and who owns it. So that was important to us. Okay, so now we're at the actual meeting. Okay, so everybody's there, just like that last picture. So what worked for us? We meet 4 to 5 times a year for 2 hours each. Okay. We can review up to 5 cases. Now, again, I'm going to go over lessons learned about how we got to exactly that, because we didn't start there. One time we tried to do 10 cases and we lost half of our members in one meeting. So this was these are the end results of a lot of failure to get to this. The meeting structure, we agreed that we will be at the same physical location for 1 year. So everybody knows this. Now, COVID, this is different, but before times, we would host it for a year, and then we'd go, like one of our healthcare systems would offer one of their conference rooms, et cetera, et cetera. The location must be secure and have audible privacy. So I can't emphasize that enough. Even though we were in a public or community members could reserve the room, it had 2 levels of security to get to the room. So nobody could accidentally, so to speak, walk into there. It had to have audible privacy, which means if I walk down the hallway, I should not be able to hear anything that's being discussed in that room. Again, this is about family privacy, confidentiality. So those things were very, very important to us. So just something to consider with the actual structure and location. So we're sitting at the table. Okay, and this is how the actual procedure of what happens. The death investigator, so the person that did the death investigation, will review the case file. They'll go through that medical examiner narrative sheet that we looked at before. The epi will, myself or one of my staff will say, these are the risk factors and circumstances that were reported in our surveillance system. And interestingly, side note, one of the most important things in our surveillance system that I didn't think was going to be the bane of existence for every epidemiologist is open text boxes. Like, we will do literally anything we possibly can to not have an open text box somewhere. But we have an open text box on our surveillance system, and that's for the investigators to share any information that they thought was relevant that was not captured in the surveillance instrument. And it turns out there was a gold mine of information that maybe didn't fit perfectly. So for example, one of the risk factors is, have you had a person, an immediate family member, die by suicide in the previous 5 years? So being the OCD people they are, they'd be like, no, it was 6 years. So they would say 6 years in the text box. Like, it got us a lot more information that maybe just didn't perfectly fit in their surveillance system. So when the epi shares that surface data, that little box is also reviewed, assuming it doesn't say anything that's too graphic or, more medical than sort of sociological. Then, so the death investigator goes, then the epi goes, and now everybody at the table would go one by one, and the members share their own specific information. So the crisis line might say, okay, this phone number, the phone number associated with this case, called the crisis line 3 times in April, et cetera, et cetera. And then we'll go around, law enforcement will share, FBI will talk about social media, et cetera, et cetera. And everybody goes around. After everyone has presented, there is the opportunity to ask clarifying questions. So if anybody at the table, wanted a little more information from the crisis line, like how long did they talk to them, or, did they hang up, or did they identify themselves or something? So that's an important part. Then, excuse me, please, we start the protective and risk factor modular approach. This is developed by Idaho State University. And then during that time, and we're going to go over that, that's the gold mine, we're going to go over that in a second, the suicide prevention coordinator, or you can have someone who is comfortable writing down information, it doesn't have to be a prevention coordinator, records all the recommendations that the committee says. So they may not be actively participating in terms of contributing ideas, but they will be recording everything that people say. And I want to be very clear, legally, we didn't want to, but the question came up, can you record suicide fatality review? Like, actually, like audio record it for transcription? And our lawyer said absolutely not, because then that enters a bunch of public record stuff or whatever. So by record information, I mean type while the person is in the room. So that's for me. And then we, for a little bit, we attempted self-care at the end of the meeting. Excuse me, I'm for a little bit of water. I haven't blabbered this much in a while. Okay, focusing questions. So all that has happened in the suicide fatality review. Everybody's asked their questions and now the work begins. These are the questions that we are asking for every single death. What risk factors were involved? What evidence-based protective factors might have been enhanced to prevent the death? And what changes in technologies, laws, behaviors that could help protect another person like this from dying by suicide. Now, this is what this slide, this information right here, particularly the second and third, this is what you need to meditate on. This is the absolute focus of the suicide fatality review, are to answer those two questions. And the most important thing I can say there is, we as, you know, as VA, as government, as law enforcement, as death investigators, we are very trained to think about budget. We are very trained to think that's not possible. The most important thing you can do for suicide fatality review is throw all those limitations away. Like if you had unlimited money, unlimited, ability to change the law, unlimited anything, what would you do? Like get really, really, really creative. And that takes, practice. So for an example of that, we had a person who died by leaving their car running in the garage. And, I'm not an automotive person, so please forgive me if I butcher this, but, I believe catalytic converters were developed so that couldn't happen. Like if the exhaust got to a certain level, the car would shut off. But this car was so old that that wasn't a thing. So we are thinking about okay, for older vehicles, what services could be provided to prevent something like this? Like really go big, go as big as you possibly can, because then it's easy to get it down to something tangible. So these are the focusing questions to really get straight when you go into suicide fatality review. Okay. This is the matrix approach. I realize it's not super sexy, but it works. Across the top here, you have the evidence-based protective factors to reduce suicide. So if someone has access to clinical care, we know these, like restricted access to highly lethal means, strong family connections, clinical interventions, cultural and religious support. We know that all of these are very protective, okay? So across the top, we have the science, and on the left-hand column, we have the risk factors. So the risk factors are, like I said, from the surveillance system, what things were present in this person's life that were risk factors for a death by suicide. So this is what you are filling out when I say the person is recording information. We're going to go through this and fill out the squares essentially, and you don't have to go in order. We tried to do that once and it was too forced, and then we just popcorned it and then they all ended up getting filled in anyway. So the goal is to line up or fill in as many as you can in a certain amount of time, system level interventions with the risk factors and the protective factors crosswalk. So let's go to the next one and I will give you an example. Okay. So we had a 7, and this is just a teeny little part of the matrix, right? So we can actually read it. So we had a 70-year-old veteran. He went to the VA for a vision screen. He screened positive for alcohol misuse. He had lived in the same household for 30 years. He had no known family. There were hundreds of history books inside his house. His house was in clean and in order. There was no medication found, but ibuprofen. So this is a person who died by suicide. So this is an example of talking through potential system level interventions for a person like this. So as you can see, or maybe this person had social isolation. So, but they were accessing clinical care. So they do have effective clinical care. So what could we do? Maybe we need to do suicide prevention training for vision practitioners. And sure enough, over multiple suicide fatality reviews, people are dying by suicide, but they're going to their eye doctor. So we're like, okay, vision practitioners, we're doing it. People don't compromise on their eyes. We knew, with this particular gentleman, there has to be very culturally specific, competent mean for firearm storage or reduction of access to highly lethal means. This person did screen positive for alcohol misuse. And so that the screening was a place, again, effective clinical care. But how do we get a person like this to the next step? How do we get them in an evidence-based program, or, with a peer group or something like that? Or do we need to go educate the provider community on the link between alcohol use and suicide? I know that seems really obvious and everybody knows that, but everybody doesn't know that. So this is just an example of how you walk through a case and get to system level interventions. So I hope that makes sense. Okay, so these are just examples of things that we did after a couple years. So the silver platter, I'll talk about that in a second, but basically you want to notice trends in your system level interventions so you can take them up to that suicide prevention council we talked about before to say, here's your shopping list to stop suicide. So we knew from our deaths, we actually had a lot of deaths for people who were involved in HR issues at their work. So we recommended, and we actually did training in our 3 major employers. We have Nike here in Washington County, the world headquarters of Nike is here, and Intel, and we have a lot of businesses here. So we actually did trainings with their HR departments on QPR training for question, persuade, and refer, and watching for warning signs of suicide and being comfortable asking the question. We also had the recommendation to when you go to the emergency department or the ER, sometimes they have TVs playing stuff. So we had the idea of having like crisis line or sort of support. You're not alone. I mean, there are certain healthcare systems that already have this, but we weren't having deaths in those healthcare systems, and we were wondering if that had anything to do with it, because they had this constant, sort of play of you couldn't avoid seeing it if you were sitting in the waiting room, basically. Apartment complexes. So we had a lot of deaths in apartment complexes. We had a lot of people who lived alone, again, socially isolated. We recommended that they put up resources for the crisis line for where people pick up their mail in the leasing office, develop sort of a system to check on residents that live alone. And, every apartment complex usually sends out a newsletter, include helpline resources in that newsletter. And interestingly, the post office and landscapers often find a lot of bodies. And that's because those people go to the houses a lot and they notice if something's different, like the mail's piled up or the house is out of order, like the grass hasn't been trimmed or something's different. When you go to the same place all the time, they notice that. So again, working with those companies and businesses to say, hey, if you see this, it is okay to call law enforcement. It's okay, building the resiliency and strength to take that next step that when they're worried about someone. And additionally, when a person is experiencing mental health crisis, informing people that they have the option of the crisis line versus always calling 911 when that's appropriate. But of course, it's always okay to call 911. So I know some of you were at my last talk, and I don't want to repeat myself too much, but some of the things that we have done for our recommendations, we found that people were surrendering their animals at the animal shelter before they died by suicide. And these are perfectly healthy, well-loved, well-fed pets. Like these, they weren't getting divorced, they weren't moving, they weren't, going away. These were totally healthy pets being surrendered without a quote unquote reason. So we ended up training our animal shelters and all the volunteers in the veterinarian and QPR. We've had multiple successful interventions. Adult foster care providers. Again, this might seem like a really odd, but it's not. Every adult foster care facility went to had no training on QPR or suicide prevention. Risk factors for suicide, it was not something that was on their radar. And again, that might just be my jurisdiction, I don't know, but that was a big step to educate that whole crew. We trained every single person in our city and county law enforcement, including the crisis negotiation unit and the 911 providers and QPR. It was mandated by the sheriff, which means they had to do it. And it took 6 or 7 days straight day and night because people work different shifts, but we have trained every law enforcement officer in this county on QPR. And, you know, a lot of, when you force people to go to a training, you know, sometimes the attitude isn't great, but it was really amazing to see some of them, their brains change, like, oh, this person could be suicidal. You know, of course, the first thing they have to think about is safety, right? But like, once they realize a person is not a threat, like, it did not appear to me that suicide was being considered. And so it was really beautiful just to be like, oh, just to see that happen in them. I mean, I don't know if it did anything, but it was really, really exciting to see. Of course, we went out to our LGBTQ organizations. We took all our data to our healthcare plan and partners that made internal changes. And in Washington County is a borderline red county, and we're very business friendly, obviously. And, you know, there hasn't been a lot of support for, or even talking about, or being able to say lethal means reduction. And now that conversation is starting to happen again. And that's coming from our law enforcement and our businesses. And it's not coming just from the health department now. So how does this all fit together? So this is my how to stop suicide in one little diagram. Okay, so you start on the left, you have a death, and the investigator goes out, and as you can see, the scrap form is completed, surface is completed for each death, and that gives us our individual risk factor. Also, the investigator sends out the letter. If there's no response, they follow up with one phone call. And a lot of times families will have questions and they'll answer it, or they say, I don't want to right now. And we're like, awesome, thank you, appreciate it. And then if we get written permission, that the decedent goes into the queue for suicide fatality review. The suicide fatality review produces our system level interventions. And then we combine that individual risk factor data with the system level interventions in this magical EpiCloud. And we take that to our suicide prevention coalition that is made up of the decision makers and say, you know, these are the top, well, we started with 30 because I'm an epi and I couldn't control myself. But then we got down to 10 or 5, like really strong. We saw this over and over again. We really recommend then, you know, for the next year, this is what you focus on to the Suicide Prevention Coalition. So this is kind of the layout or the process of the whole system and how it comes together. Okay, so what went horribly wrong? A lot, but this will save you years of suffering, right? So listen up, if for those of us who are still with us. So what were the barriers with investigators and medical legal death investigators and myself and my team actually going out to scenes? And Jessica Rose hinted at these a little bit earlier. There's a lot of trust and fear there, you know, because I don't know what I'm going to do when I get to a scene. If I mess it up, it's going to be really bad. You know, there's law enforcement is like, why are you here? This is not an outbreak. You know, family. So one of my investigators is a Marine Corps sniper, 2 tours Vietnam, and he has a presence. Let's just say that. And, you know, so we'd be going to scenes together, and the family would come talk to me because apparently I look much less scary than he does. And I mean that in the absolute most total respect way. They'd be like, so what do we, and I'm like sitting here going, oh my God, like, you know, I'm not supposed to be talking to anybody. I don't know what, you know, so that was, you know, whereas he'd be off talking to law enforcement and the family was talking to me, and I'm like, oh boy. So that was working through that. It seems obvious, but going to death scenes is very, I don't even know how. There's nothing that you could do that would prepare you for it. There's nothing. There's like nothing you could read, say, do. I could describe everything to you and it would not at all prepare you to see what you're going to see. And Charles told me at the beginning, one of my investigators, he's like, there's going to be one scene that you can't handle. And nobody knows what that scene is going to be, but it's going to happen. And I was like, okay, well, for me, it's going to be something with dogs because I just can't, right? And so I went to a scene and there was a dog involved and I was okay. And I was like, woohoo, like I'm superhuman, like I don't have any. And then I got my one scene, and I'm not going to traumatize anybody, but going through it, but there will be scenes that you can't handle and you have to, you know, I politely excused myself, and it had nothing to do with body. It was the circumstances, but that's a challenge, and having the trust and respect to, you know, tap out and politely and without anybody noticing, you know, going back to the truck or whatever. And isolation. In the VA, all the military and all our veterans here, I probably don't need to even say this, but believe it or not, your family, my family did not want to hear about death scenes when I got home. They didn't want to hear about my day. They didn't want to hear about the horrible things that I saw and how it affected me. Nobody wants to hear about that at all. So the only people you can talk to are, you know, law enforcement that was there, or your peers, right? There's nobody else to talk to, and you have all this built up and you can't share it with anyone. That's really, really hard. I don't know, but I imagine that would be similar with veterans and the military. So that was brutal. And then it started turning into, like, I would go here, we'd go to the lake, and I was like, oh yeah, I pulled 3 bodies out of here. Like, I was, you know, that was a normal in my head. I wanted to share that experience and talk about and how we used for prevention, and these were the steps we took. Like, it wasn't, but it was like horrifying to everyone. And so having to constantly censor myself to not do that was very hard. So the scrap form and surveillance, it took 8 months for us to get to the final form that the MEs blessed. At one time, we had 6 different versions going at once, which made data collection a lot of fun. We had to figure out how we were going to know if we missed one, like if somebody forgot to fill out a form. Back in the day, we weren't doing this online. We were doing it on paper, and that was very tedious. The time to do that was not protected. Like I said, we didn't have any grant funds for that. And there was no manual for how to combine the qualitative and quantitative data. You know, there are mixed methods experts. I do not have one of those, so we just kind of had to figure it out as we went. Yeah. Vicarious trauma. So yeah, one of the hardest parts of suicide fatality review, which I'll talk about in just a second, is how rough it is for everybody. It's brutal. It's just like child fatality review. It's really, really hard. Just because you're not at the scene doesn't mean it's any easier. Sometimes it's worse reading the information. So and then you also have sort of the people together that are coming from different aspects, bitey, scratchy, and touchy-feely in the same room, trying to talk about the same things, and that's really challenging. In terms of the challenges that we had for suicide fatality review, due to the traumatic nature of the review, we have been unable to keep a survivor of suicide on our committee. Nobody's been able to make it through one meeting. And it was so traumatizing to them, we stopped. Like, we just ethically felt we want that voice, and everybody at the table had some sort of lived experience, but we couldn't make that work. Even law enforcement was exhausted after trying to do more than 5 cases in a meeting. Like, you just don't have it in you. That's it. You got to have faith representation. Sometimes, again, this is not something faith leaders necessarily deal with all the time. So it's, again, hard to keep them at the table. When we started, we were trying to think of system level interventions without any sort of model. We had to figure out how we were going to report back to the family in an aggregated way so as not to identify anyone. We did start out with a lot of, why didn't you ask blah, blah, blah. So, you know, that list of things I said we didn't want to do, that's how we started with everything, you know, because it's a lot easier to ask than it is to think of system level interventions. We dropped self-care. It's bad. I know. It was, we had people who really needed it, and we had people that left immediately. So, you know, I would show puppy videos or something for people that wanted to stay, but if others wanted to leave, they could. But we essentially dropped that, and I'm not proud of that, but I could not get the balance right between self-care and not on that. And interestingly, we had so many people consent, we actually were backed up on cases for an entire year. So that was a good thing, but it was a challenge. So I won't go over this too much, but basically the filling out the form for the investigators takes no time. Any epi would be happy to analyze this with the standard software. I put estimates for the hours for each investigator or prevention coordinator and epi, just to give you an idea of what the lift is there for reference. But again, we did this without any additional funding. So why does this work? And our state medical examiner has wanted to make this mandatory for years, our system, and I have begged, well, it was her at the time, now it's him, not to, because our investigators are wanting to do this, which is why the data are good. If they were forced, I'm not so sure it would be good. Might as well just use the NVDRS. We are patient. We knew it was going to take multiple years to get the data we needed. And we make sure we have a bunch of people at the table, as many different organizations and systems represented. So we have good community voice, and we have a very clear feedback loop where recommendations go to the prevention council, and the prevention council gives suicide fatality review feedback, and we have a clear loop so everybody knows what people are doing and why. So the unintended consequences, we actually were able to detect some suicide clusters we couldn't find another way. We had normally have 0 youth suicides a year in Washington County. We're very fortunate, but we had 3 in 1 week. And if we wouldn't have had our surveillance system, we wouldn't have known that happened. And that allowed us to get post-vention activities on site weeks before normally would. Now, how to get the MEs and the coroners at the table. Suddenly, when public health realized the value, we had a new ME truck. They're all going to national trainings. I mean, our budget just went up, and I didn't ask for any of that. It was just because people, administrators, elected officials saw the value of the death investigation system for the first time. And that's a good reason for the death investigator system to participate. And of course, the big take home is we actually reduced our population suicide rate 40% from the start of this. And this year, 2020, oh God, it's 2021. So our most recent year of data, we had our first single-digit suicide rate we've ever had in the county. So that's the impact of this. I'm going to tell a quick little story. Next slide, please, Jessica Rose. So this was the first time I was going to Humboldt County, California, to train them on suicide fatality review. And I was in the Portland airport at 8 a.m. on a Saturday or something. And I was sitting at the bar, as one does. And the seat next to me was open. And this gentleman came and sat next to me. Now, I didn't look at him, but I could tell from the corner of my eye, he had a sweatshirt on that had, it said Afghanistan, and it had like the bars, and it was casual, but it was clearly like a military, like issued sweatshirt, and so, he ordered something, and we start talking, and it turns out he just got back from Afghanistan. He had done 2 tours. And, we just ended up talking. I've worked with a lot of older veterans, but I'd never worked with like a younger person before. And I say younger, he was probably like 30. So that's what I'm saying with that. And we ended up hanging out, and I challenged him to a duel we had hours before the flight. I challenged him to a duel on one of the little escalator things. And, in my head, I thought, like, if I tied his legs together and one of his arm behind his back, like, I'd totally win. Like, we each had a fork. And so I should have known by the way he laughed that I was doomed. But we're in the airport having a duel on an escalator with forks. And before I even knew it, like, I was on the floor, just like out. And it was hilarious, and we were laughing, and it was great. We had a lot of fun. And so I asked him where he's going. He said, California. And I said, oh, me too. I'm like, where are you going? And I don't remember the name of the airport that you fly into Humboldt County, California. It's Arcadia or something. I don't know. It's like this really teeny little airport. And he's like, oh, that's where I'm going. I was like, really? Okay, cool. So it turns out we were on the same flight. Total coincidence in the entire airport. So we get on the plane and he's in first class and I'm by the bathroom because I'm a government employee in the back of the plane. And I felt like we were really having a good conversation, and we're starting, I talked about suicide prevention and what I was doing, and he was interested, but then we, had to get on the plane and we were separated. So I was sitting there thinking, and, next to the bathroom, I'm like, I need to give him my business card or something. Like, I feel like I really want more experience with younger veterans. And I'm sitting there trying to figure out what to do. And the airline attendant comes down the airport or the path with a cart. And behind him is Tony. And Tony is the veteran. And he's like, Kim, hey, Kim. And I'm like, oh my God. I'm like, hey, what's up? And he's like, you should come sit by me. And I was like, and the stewardess looks at me, he's like, try it. I want you to try it. The look your mom gives you when you like reach for the candy at the store. And I was like, yeah, no, okay. And so like, he's trying to climb over the cart. And so she goes in the back, he grabs all my stuff. Now I probably had, I don't even know how much stuff I had, but he like just picks it all up like a gazelle and whoop, we're in first class. And it just so happened the only seat open on the entire plane was the one next to him. So I sit down in first class and I am so uncomfortable, right? Like I'm not supposed to be here. I got to follow the rules. And so the first class attendant comes down and she's like, so I don't think you're supposed to be sitting here. I'm like, I'm so sorry. I will go back. I'm so sorry. Just like immediate apologize. Please don't land the plane. And, Tony's like, so I actually just got back from Afghanistan and I would like her to sit here if that's okay with you. And he's totally, just being friendly. And I was like, is this going to work? And sure enough, she's like, thank you for your service, and sits down. I was like, hell yeah. So I'm sitting there and we're talking. And, the plane, we're getting sleepy from things. And, he's sitting there and he eventually gets warm and he takes his sweatshirt off. And I see that he's covered in tattoos on his arms, and for Oregon, that's not really unusual. I asked him why he was going to California and he said he was going to a funeral. He said his friend died, and I said, I'm very sorry to hear that. And when I was sitting next to him, I looked down at his left forearm. He was sitting to my left. And he saw me looking at his left forearm. And on his left forearm were a list of names. And he's like, do you know what that is? And I said, no. He's like, these are my friends that have died. And I said, I'm sorry. And he's like, do you want to know how many of them did it themselves? And I said, nothing. And he said, all but 2. And, that it was, I couldn't even speak. I didn't have anything to say. And to me, I don't know what was more heartbreaking, the fact that the list of the names was so long, or that he knew he needed to leave more space. And that changed me forever, that conversation, that experience with Tony. I ended up giving him my card and we talk every now and then. He calls me from a block number, so I have no idea where he is. But he was actually, his friend died by suicide and he was going to a funeral. And we ended up having that whole conversation and sitting next to each other and just listening to him and his experiences and talking about loss and starting to learn a little more about that. His perspective was educational in a way that I can't even articulate. It was incredibly life-changing for me. Next slide, please. So my ask for everyone here is never grow a wishbone where your backbone ought to be. This work is really, really hard. This problem is not going to go away on its own. It's not going to disappear. And we all have to step up and do the heavy lifting so we can get our suicide rates down. And next slide. So I can be better at my self-care. Here's Jasper. He's an 110-pound English chocolate Labrador, and he's dumb as a brick and lovely. So thanks, Cheryl. So thank you everybody for hanging in there with me today. I really appreciate that. And I'd be happy, I know we're at time, but I'd be happy to answer any questions anyone has. And thank you for listening today. I really appreciate it.
Thank you so much for sharing. That's definitely a heartfelt story. And I think I can speak for everyone that, you know, we all come to the table with our own connections. And, you know, that was very special for you to share that with all of us today. Does anybody have any questions that they would like to ask before we wrap up today? I know this was a lot of amazing information and we ended on such a great heartfelt note. Of course, lots of thank yous. Well, for those of you, if you're not signed up to receive our newsletter, if you want more information, make sure that you reach out to us and we'll get you signed up. We are hoping to have a second session to dive in a little bit more deeper on this topic. So definitely stay tuned as we send out information for that when it gets finalized. And on that note, I'm not seeing any questions come in the chat. So I just want to thank you so much for being here today, all of our participants, but especially thank you to Dr. Reap for sharing all of your knowledge and sharing all of your stories in a way that was enjoyable on this Friday afternoon. So again, thank you so much, everyone, for your time and for being here and doing the work that you do.
Thank you. Yes, thank you. I have a question. If you're allowed to contact me, I sure hope so. I want to hear from you. You guys can, you want my cell phone? I can give you guys my cell phone. Yes, absolutely. Jessica Rose can give you my email or phone or whatever you need. I'd be happy to share.
We can send that out when we send